And thank you. Welcome to the PM Express Manifesto Tracker. Tonight, I'm delighted to be joined by Dr. Abeka Nkrumah. You've seen him on our promotions today with the University of Ghana Business School. He is into the area of health, and I've seen that in the conversations that many have described as a health economist. Right to describe you so? Yeah. And so he's the right man for the job to help us tonight walk through. He is my co-host for today's analytical part of this PM Express, after which we'll be joined by Dr. Manibama and Dr. Okoboy, two medical doctors representing two of the main political parties. What we do here is to help you decide where to pitch your tent. This is around a view. It's health is the area that you are interested in. If health is the part of the sector that may make up your mind, you want to pay attention to the analysis and the interview subsequently, and hopefully it will help you make a decision if you haven't made a decision already, which are the two parties to pitch your camp about. I want to quickly go to what we're doing tonight, and so this is the health sector debate. And Doc, we could look at some of the details that we've put together in this. One of the things we do quickly is to give you a pictorial number analysis of the two manifestos, because that gives you a sense of what we are talking about. And this is the health sector in numbers. If you look at the NDC manifesto and the NPP manifesto, Doc, in terms of pure counting, the NDC has far more share, programs and proposals for the health sector than the NPP has. And we counted 70 of them. There's a lot of promises to plow through. We counted 22 for the NPP. And you are beginning to form a view on why this possibly might be the case in terms of the sheer number of the promises.
Well, thanks very much, and good evening to our viewers. So I'm not surprised that the NDC had 70 and NPP has 22. In fact, I've actually run through the manifestos from 2012 up to 2020. I would say that the most fascinating manifesto I saw from the two parties from 2012 to 2020 was the NPP manifesto for 2016, because it looked more structural. So I would imagine that NPP being in government and having started some of the numerous promises they gave in 2016, I didn't think it would be good for them to still carry out with a lot more promises when they've not finished with what they set out to do. On the other side, NDC is thinking of coming into government, and so it is ideal because it looks to me as if they are starting from a clean slate, and also looking at the backlog in terms of what they promised in 2012 that they couldn't achieve by 2016.
Yeah, you use the word backlog, and we see that in the next slide here when we begin to look at some of the similarities. You quickly see that the NDC is promising to employ the backlog of qualified health professionals. And this is similar to what the NPP is promising, because this is the similarities, how they are similar in some of the promises. The corresponding program proposal for the NPP is continue to recruit trained health personnel and distribute them equally. I mean, they are, in essence, this is a personal question, right? An intervention to try and deal with the personnel challenge in the sector. But this is about backlog. Yeah. This is about recruitment. It's an interesting sort of way to look at it. One is looking at, let me address those you haven't employed. The current government, I don't know whether they're putting this because they believe they fixed the problem of the backlog, but they're moving past the backlog and talking about recruiting more.
So for me, I think that it's basically semantics.
Okay.
It's the same, because these are talking about backlog of qualified health professionals. The deputy minister may correct me when he comes in, but I think that since they came in, they've done close to about 20,000 health professionals. So it's not as if there is a gaping hole. But it's a continuous process. But I think that is just choice of language, and I see it as basically the same.
One of the quick similarities you begin to see when we begin to go into the detailed analysis is that both of them are heavy on health infrastructure. So you see NDC is talking about establishing infectious disease units, establishing 2 national infectious disease centers. MPP is talking about construction infectious disease centers also. Why is that COVID-19 is playing a role in shaping what they are promising for the health sector? Construction of the Ghana Center for Disease Control. So these are the areas where they're very similar in what they're promising. Let's get into the detailed analysis now. And Doc, you've developed a framework for the analysis. Okay, you say relevance. You're going to look at the manifestos, the two of manifestos, and match them against, is it relevant? Is it feasible? Is it politically feasible? And I like that. We'll tell you what that means shortly. And is the fiscal integrity of these? Let's get into the details. You get to understand what these parameters are shortly. Let's start with the specifics of relevance of the promises. You conclude that both manifestos seek to achieve universal health care and that this, in essence, is relevant. Why?
Well, so if you look at the two manifestos, it seems to me that the preamble is around achieving universal health coverage. And right now, for almost every developing country, universal health coverage, I think, is the most important thing right now, because that is SDG 3, and that's what from the donors, from the government. And so for me, from an international level, okay, that is the country sort of trying to achieve its international commitment.
Okay, so and you see that on your screen here. You talk about SDG 3.
Yeah.
And that both manifestos sort of responsive to this international commitment that we've made.
Exactly.
Okay. So I guess...
And then at the national level too, now everything that is being done in the health sector, it's all aiming at how do we make sure that we have universal health care, universal health coverage. Okay. And so for me, I say the promises are relevant because all of them are seeking to hone in terms of achieving universal health coverage. Right now, there is a roadmap that is being developed, okay? And that roadmap is supposed to get us to this ideal state of universal health coverage. Okay. So it is in that perspective that I think that they are relevant.
Both of them are relevant. Okay, let's go into the areas where we begin to isolate the two parties. So feasibility of the promises. This is a very important, I guess, metric to measure them against. You say that the MPP relatively economic with its promises compared to the NDC, and that goes back to the first main slide we showed you about the sheer number of the promises for both. That's what you mean there.
Yeah, that's exactly what I mean. Yeah. That again, if you see, when you go to, I think, and funny enough, the health section of their manifestos all start from the 60th page. NPP starts from 62. And NDC, I think, starts from 61.
Who's copying who?
Okay.
That's just by the way.
Okay. You see that NPP looks at what they promised in 2016, what they have achieved, and where they hope to go. And then NDC also seems to look at what do we want to do and how do we bring in what we couldn't do from 2012.
The unfinished business.
Exactly. Okay. So for me, the NPP seems to be quite compact in terms of the promises, but NDC seems to have a lot. But again, what I should say is that if you look through their manifestos, there are certain things that are repetitive. They're just the same.
Okay. So let's talk about the first one. Let's talk about technical feasibility of the programs. And you talk about almost all the programs proposed by the two parties are technically feasible to implement. What does that mean? Okay, so in terms of the technical capacity that you need to implement those programs. So for instance, if NPP talks about Agenda 111, can they find people who will build those hospitals? Yes, they can find people who will build those hospitals. If it's about cement, do we have capacity to produce the cement that will build that? Yes, it is possible. Okay, so when I talk of technical feasibility, I'm looking at it in terms of that. So the NDC says that they would do free primary care. Is it technically feasible? Can we have people who put the policy together? Yes. Okay. Okay. So if I look at it from that aspect, yes, it's technically feasible. This part is, I guess, where it gets interesting. The capacity requirement for implementation. You see, some of the programs proposed will have capacity challenges to implement. I want to take it to the next slide because that begins to break that down a bit more, Doc. Here, let's isolate some of the key promises and then let's measure it against this. You say the NDC, they want to turn all regional hospitals into tertiary hospitals. You ask a big question, questioning over personnel to run these facilities, right? Similar to the MPP's Agenda 111 hospital that they want to build. Building additional medical school facilities. The next slide will tell you, we'll give you the analysis that Doc has put together for us tonight. You say the evidence shows that we have a capacity deficit to man these infrastructural programs in health?
Great. So, for instance, like I've said, technically it's feasible to put all these things there. Just like we put Bank of Ghana, we put UGMC, the Upper West Regional Hospital, all these structures all over the place. The point here is that if you turn all regional hospitals into tertiary hospitals, what it means is that you need a certain caliber of personnel to be able to man them. Where are they? I'll give you a typical example. Every man or every male, 40 years and above, okay, is a potential urological candidate. Yet we don't have up to 15 urologists in Ghana.
Goodness me.
So where are you going to get the people to run these tertiary facilities? And the next question is that, okay, maybe you say you would want to train them. I want to see the plan to be able to train
bring
them.
that expertise in.
Because for training that level of personnel, it's not just academic, it's apprenticeship. So they need the specialists themselves to be in those facilities.
And it takes a long time to train a specialist in that sector. And you gave two examples that are so apt because it's been playing out in the media circle for a while. And this is the case of the UGMC and the Bank of Ghana hospitals that have remained underutilized. Mm-hmm. It hasn't been fully sort of operationalized. And you identified three reasons possibly why. Mm-hmm. One is appropriate staff, mm-hmm. Two is working capital requirements, and three is appropriate business model, which is a challenge that both the MPP and NDC will face if they attempt to implement their manifestos with all the heavy investment they want to make in building infrastructure.
I'll give you, so for instance, I'll just isolate, say, UGMC, and then I'll apply these.
Okay.
So for instance, if you want to operate UGMC full capacity, maybe you probably may have to have capacity of Kolebu to be able to do that.
You have to necessarily reduce the specialists at the Kolebu by half.
Exactly, because where would the specialists come from? UGMC is a quaternary hospital, okay? So under normal circumstance, if Kolebu cannot handle, then you refer to UGMC.
Oh, interesting.
Exactly.
So UGMC is above Kolebu.
It's supposed to be above Kolebu because it's supposed to produce or provide quaternary care. So if Kolebu cannot handle, rate is secondary. So if rate cannot handle, ordinarily it will go to Kolebu. If Kolebu cannot handle, then from the gatekeeper system, it will come to UGMC. So the sort of people there are high-end specialists that we don't have many of them in this country.
I see.
Okay, so if you want to open it full capacity, you would need to pull people. At the moment, when you go there, you would realize that even for lower-end people, nurses, doctors, they have actually pulled them from different places and put them in UGMC. What it means is that a hole would have been created from where they pulled them from.
So you cannot fully operationalize UGMC without causing some serious challenges at Kolebu.
Exactly.
In terms of personnel.
Okay, and not just Kolebu, but even other places.
Wow, that's quite startling to hear.
For instance, I know of one person currently in UGMC. He's one of the best gynecologists I know. Okay, he was pulled from the Eastern region. What it means is that
there's a hole in the Eastern region you have to fill.
Maybe somebody will go there, but you may not have that same person.
Okay, in terms of their know-how.
Okay.
Okay.
And UGMC, the appropriate business model.
Okay.
You see, if you want to operationalize UGMC and make it sustainable, one of the things I have said is that if UGMC continues to be in the hands of government, it's going to be very difficult. Because if you want UGMC to run and be very sustainable, okay, plus or minus, you're looking at around $40 million a year in terms of revenue to be able to cover their cost and to be able to cover depreciation on the assets. I've done some figures on that. Now, the amount of money UGMC can generate locally is just about a third of that amount. So the only way to make that money is to look at the international market, maybe West Africa. Okay. And the people who will come are people who have the resources. And normally those who place them are the insurance companies that sit in London or that sit in Berlin or that sit in New York. They will not send their patient here unless they have a certain assurance that they are going to receive the same quality of service that if you send them to, say, the Yale Medical Center or the Harvard Medical Center. So
where is the money going to come from?
Exactly.
The question you're asking. And so it's a very important point to observe because I noticed in the NDC manifesto, for example, that they are promising in the next 4 years to operationalize the next phase of the UGMC, because this is in the first phase, and then there's several phases. This is the first phase, and we haven't fully operationalized yet. But they're promising to move that into the next phase. So that will be a problem if you attempt to implement the next phase of the UGMC. You meet the challenges that you're talking about. Yes,
unless you are prepared to come up with an appropriate business model to be able to do that.
Also, you say having a new medical school, for example, means additional tertiary hospitals better equipped with the faculty to teach. Where are you getting this faculty from is a key question you asked. And where is the plan to bring them? You are asking both parties to show you the plan.
Exactly.
The plan to get the capacity to run all these. Okay, great. I mean, so let's move to the next major one when it comes to the NDC is promising to reduce maternal mortality by 50. You have an analysis on this. You say this is just not possible.
It's just not possible.
This is your analysis here.
Yeah, why do I say that? If you look at the data from 2000 to 2017, okay, we've reduced maternal mortality by 36%.
Okay, so these are the figures that Doc is talking about.
And that gives you an annual average reduction rate of about 2.1%.
Okay.
So in 4 years, you cannot do 50%. And why do I say so? One, right now, we don't even have the resources that we used to have added from 2000 when we had the health sector swaps with money pouring in from donors, because right now we are middle income. Number two, we were projected to grow at 6.8%, but now we are going to do 0.9 per the finance minister's report. But as we are talking, we are doing about negative 3.4%. So where are you going to get the money to pour in to be able to do this? And again, questions of diminishing return, because at the early stages, when you start investing, okay, the marginal productivity of that investment is higher. But at a certain level, it tapers off. So I cannot possibly see this being possible.
Okay. I mean, so that is your verdict today based on the numbers that you looked at. Let's look at the fiscal integrity of the promises. Both parties promise there's a spree here in terms of, you know, the things that they're promising. But you talk about the finance link. Let's look at the free primary health care that the NDC's promise. There's a similar one for the MPP that will come what I will come to shortly. But let's look at that for a second. You said is it financially feasible to do free primary health care by the NDC? And you do some of the analysis here. Your analysis say to implement this, it will cost some $1.5 billion.
Yeah.
Okay, and it's about what? It's about $2.3 billion. That's the range from 1.5 billion to 2.3 billion. And you say the projected annual revenue from NHIS is way below this. And I saw some figures that show it's way, way below this amount, for example. So the question is, if this is implemented with the NHIS, under the NHIS, why are you going to get the money to implement this?
So let me say that the free primary care is a very innovative idea, fantastic idea, which I like. And the reason why I like it is because I've argued that if you take the health insurance, okay, the whole fund, the premium constitutes just about 5%. Yet the premium has become a gatekeeper from keeping people, poor people, into the system. So if you go free care at the primary facility level, not necessarily primary care, but at the primary facility level, that is fantastic. But the point is that we need to show where we're going to get the money from. Now, if you look at our primary health care cost per capita for Ghana, okay, as of 2017, that is around $49 per capita, which is close to Brazil, which is about $50 per capita. Now, if you look at the African average, that is $77 per capita. So if you use the minimum point, which Ghana is doing, that gives you about $1.5 billion, which is about 8-point-something billion cedis. Okay?
That you're required to implement this.
Yeah, and this is even more. But if you look at 2019, the collections from NHIS and then the SNITS money was just going to give us close to 4 billion cedis. Okay. In 2020, it was just about 3-point-something that is projected on the basis that we're going to grow at 6.8. Now that we are going to grow at 0.9, what it means is that that will go down extremely. So you are not going to get the money into the NHIS. And so I'm asking, even if you were going to get the money, you probably will have a deficit of about 5 billion cedis.
That's huge.
Where is that money coming from?
Okay, so let's look at what the MPP's own challenge is. The same NHIS question. They want to increase the coverage under this to cover preventive and promotive services. And this is so interesting. It's true. with a lower coverage, the scheme is perennially indebted to the health facilities. We've seen that play out under this government. There have been threats by the providers to withdraw services for a long time. The government had struggled to find money to pay. Last time they updated, they said they paid $1 billion backlog that they owed. And you've seen that in your analysis playing out. You say you're going to extend this further. Meanwhile, you haven't fixed the challenge of finding money to pay those who are rendering your service now, even at the limited within a limited scope it currently is.
Yeah, I mean, it's great because in terms of the idea behind it, it's also a fantastic idea, which I applaud them for that, just like I did for the other one. But I want to see the resources because under the current coverage, okay, which is much lower, the scheme was indebted, okay, somewhere, that is before 2017. It was an average of 7 months. Now we've tried to clear it. I think that now we are hovering between 3 to 4 months.
Yes.
Okay, 3 to 4 months.
Yeah.
And we are indebted to these facilities. So if you open it, it means there will be more cost. At a point where we are going to grow less and money coming in will be less. So sometimes I ask myself, is it that people haven't seen that COVID really has effect on our revenue?
And one of the things that I'll put to them when we sit down is that if you look at the OECD has put a report out that says that private finance that usually was there for all of us, developing countries to access, to do some of these things, is going to dry up by an estimated $700 billion.
Which I made mention of.
And so that pool is already dried up, and so where are you going to get the money from is the key question to ask both health infrastructure. And this is a contest for me because and we'll focus a lot on this. Both MPP and NDC to construct several hospitals, both at the national district and really across the country. It's a spree of who is building the most brick and mortar when it comes to health infrastructure. But let's look at your analysis on this area. Can we afford these facilities? But you ask even more important question, even if we can afford, is that what we need? I mean, some interesting analysis here.
Yeah, so the first issue is whether we can afford it. Okay. It doesn't seem to me that we can afford it. Okay. But even if we could afford it, my question is, what does that really solve our problem? Because right now we have health facilities there. I was just talking to somebody today who went to Sefi, and there are facilities that are not properly equipped, okay? Can't we begin to equip those ones? Because over the last 10 years, we've had substantial investment into the health sector. And I think that there are alternative ways that we can use. One, for instance, I'll tell you, if you go to UK, take a city like Manchester, which has a population of around between, I think, 4.5 to about 5 million. And Greater Accra has something around 3-point-something million. But the city of Manchester has only 2 hospitals. Okay. The rest are all GP surgeries, which are owned by private entities. But they are paid for by the state. So I'm advocating for what I call a provider financing split. Okay. And in the bigger cities, we can get the private sector to come in. Once we can fix our NHIS and begin to pay market rate to the service providers, people can then go to private people so that they would then invest in infrastructure and government can save on resources to improve quality, because now quality is a much more important issue.
I mean, very interesting point. I mean, just to compare the NDC to the MPP, MPP appears to be more ambitious with infrastructure when it comes to this area. 111 hospitals they want to build across the country. That is very, very ambitious, but I haven't seen the costing. I mean, NDC promises a lot too, but they haven't put in numbers yet, okay? I mean, so, but we'll interrogate that. Where are the numbers? How much is it going to cost us? And here's the NDC MPP. I like this part a lot because to employ backlog of unemployed health staff is what NDC is promising. MPP is promising recruit more personnel and distribute them. We touched on this at the beginning, but you have some very interesting analysis on this. The MPP has employed over 17,000 plus health staff already since 2017. Do we have the capacity at the moment to absorb all these, from compensation costs to capacity to effectively utilize them, as both of them are promising?
Yeah, so that's the question that I'm asking. One, if you employ, you're going to scale up the compensation cost, okay, which is already high. Now, even if we have that, my question is, can we find alternative ways to make sure that our health personnel become a lot more efficient? I'll give you a simple example in a case that I was looking at in UK, where nurses had to change a procedure, okay, into a digital process. Yeah. And by changing that procedure, what they did was that they were able to save something that used to take them 1 hour, 20 minutes. It now took them just 20 minutes. So they could spend the 1 hour on actual care. Okay. So I'm asking myself, are we better off looking for alternatives to be able to do that? And I'll give you a typical example. Recently, I was in Kolebu, and nurses were doing a work that I think would be work for clerks. Yeah, administrative work. Exactly. They should be doing but if that system were computerized, they probably would save a lot more hours and invest that in quality care. Is the argument that it's not necessarily a case of just flooding employment, so. Okay, but look at what you have now, and look at how can I make best use of the hands those that in the system. The final analysis we'll do is what you call the political feasibility. I mean, and I like this bit. NDC says to enforce the NHIS law to ensure that all NHI collected goes into the fund. We've seen historically, and this is fundamentally your argument, and it's true, historically, both NDC and NPP, they've woefully failed to simply respect what the law says in terms of when you collect the fund, put it where it's supposed to be. You see, you don't think that this is even feasible going forward unless you change the structure? Yeah, politically, it's not going to happen. If, for instance, they said we were going to repeal the current NHIS law and make sure that there is a new law that says that we have a earmark fund sitting in the Bank of Ghana in the name of NHIS, and the money goes into it direct without it routing it through the consolidated fund, then I'll believe them. Why is it the case? This comes from the structural rigidities in our budget. So the Minister of Finance has very little discretion. Now, if you take compensation, okay, compensation is just about 31%. Huge, yes. Interest payment is about 25%. Yeah. So here we have about more than half of what you are making. Gone. Before you then can talk about statutory payments like District Assembly Common Fund, goods and services, etc. Yeah, capital expenditure. So the Minister of Finance has less room to maneuver. So whenever there is an emergency, they can only go straight into this and dip their hands. I mean, we've seen the excuse given by all finance ministers why they don't simply respect the sanctity of this law and keep the money there. Because the question I'll ask you is, Evans, if you are a finance minister, which one is a bigger national security issue? To pay your debt to NHIS or to leave the doctors hungry and they being on the street? You have to pay the doctors. Exactly. So you dip your hands into this and fix this. And also, extending maternity leave is a good one, right? I mean, I like it. I mean, and I like it. I like maternity leave as well. But we need to look at cost issues also there, right? Because that's a key issue. I mean, this is really straightforward. I mean, we'll put that to them. Now, this is one of the last slide. You talk about some things you've observed in both manifestos in terms of the area that they emphasize, but areas that you believe they have neglected but emphasis need to be. I want you to quickly run us through this particular part of, because this is already, they are doing this. But community participation is a bit missing, you say. Sector leadership and governance is missing as well. Access to essential medicines and technology is also missing. Okay, so I'll start first from sector leadership and governance. We have, if you do an analysis of the sector, okay, a political economy analysis of the sector, one of the things that you will see straightforward are structural issues within the sector in terms of the configuration of the sector, how people are appointed, the link between the bureaucracy and the political leadership, and all those sort of things. Again, multiplicity of institutions, okay, which have roles defined, but the point is that they don't seem to be able to work well and things like that. These are things that ought to be addressed, because until those things are addressed, there will be plans, and yet implementing those plans might be difficult. Again, community participation. Let's talk about a simple example of COVID, okay? I mean, we seem to have a medical approach to COVID, but I think that COVID is a community issue. Look, you could have the biggest hospitals, all right? But if you are not close to the community, where the community hears you and the community adheres to instruction, you can't deal with COVID.
True.
So for me, I've said that COVID is not a medical issue that needs so much infrastructure. It's a community issue, okay? Then we talk about access to essential medicines and technology. The two parties have talked about it, but it's just a bit scanty. We will want to see, for instance, what happened in India. Where
Dr. Manibama disagrees with you. He'll join us shortly. Okay. Yeah, go on.
What happened in India, where government actually came up with a clear strategy in terms of how they pitched the pharmaceutical sector as a major revenue earner. But if, for instance, people talk about, oh, we would encourage this, we would take this start, we've been doing that for a very long time. Has it fundamentally changed the structure within that sector? No.
Okay. I mean, Doc, thank you very much for joining us with the analysis. So you have a picture now of what it is that the parties are promising, where the challenges are, and where they probably need to address it. But probably possibly forming your opinion on which of these promises maybe really is feasible, is relevant, politically feasible, and we've talked also about some of the areas they should be focusing. Coming up next is Dr. Manibama, who is a former communications minister. He's a medical doctor himself, by the way, and also the deputy health minister, Dr. Okoboi, will be interrogating their manifestos. I always say on Manifesto Tracker, they'll be selling you their programs. This is a marketing expedition for both of them. They have to convince you that they have the best interventions to make your life better when you go to any health facility. Listen to them, pay attention, so you can decide which of the two parties have the best health interventions for the next 4 years for you. After this break, they'll be seated. We'll get to dissect and hear their thoughts on the analysis. Stay with me. Thank you very much for staying with us here on PM Express. So my guests are seated now. To my right is the Deputy Health Minister, Dr. Okoboi, who still practices, by the way. I understand at LECMA. True, Doc, you still do. Okay. And then also Dr. Manibama. He is a doctor first before he was a minister. He will not dispute that. Yes. So you also practice? I do. Oh, you do where? Oh, okay, great. To see if I can pass by for free healthcare. You're promising free. I'll come for free.
Definitely. Okay. Once it is primary healthcare, you have it.
Oh, that one is already very, very inexpensive. By the way, so we're going to delve into the details. You've heard the analysis already. Let's go straight to it. And let me start with you, Dr. Manibama, about the very ambitious promise to provide free primary healthcare. Okay. Our analysis, as you've heard Dr. Abeka mention, that the biggest question you have to answer there is the financial feasibility of this. Okay, where I always want to start is if you make this promise, you must have costed it. Have you?
Evans, thank you very much, and a very good evening to Dr. Okoboi, my colleague, and our Sector Deputy Minister, and also thanks to Dr. Abeka for his analysis, assessment, and a very good evening to viewers. If you begin a discussion of free primary healthcare and the manifesto from costing, you'll be shortchanging the very good people of Ghana.
Why?
Who must be appreciating even what is in it. Let me just tell you something. You must know the value of something before you even consider the cost.
You're sounding like John Kufuor.
Let me give you this for you to have a look.
This is an MPP quote you just put out.
My colleague, Dr. Okoboi, can also have that. And basically, what am I saying?
So, by the way, I want to show you if you can see it on the screen. If you're, so this is, let me just run it by our listener. What he's given us is free primary healthcare. Let's walk the talk. You talk about what? Alma Ata Declaration?
1978.
Okay, well, what is that, by the way?
In 1978, in Alma Ata, the World Health Organization, together with the nations that are part of the WHO, declared that there has to be free primary health care. And the decision was that it is a universal social goal that must be achieved. Unfortunately, since 1978, it has eluded us. Fast forward to the year 2000, the Millennium Development Goals also came. And we were signatories to also that. The difference between the MDGs and the Alma Ata Declaration was that the MDGs were more vertical, as in they look at HIV. So we are dealing with HIV. They look at maternal mortality. We are dealing with that. Instead of having a more integrated thing. Then you look at 2008, fast forward, under President Kufuor, the Kampala Declaration also, which also emphasized the need for primary health care. Then 2015, under President Mahama, the Sustainable Development Goals, Goal 3, which emphasizes health for all. And that also improved on the MDG's vertical approach and went back for the Alma Ata Declaration, which looks at more integration. What has happened? We were all hopeful. 2015, 2016, NDC left office. Now we have 9 years to 2030. Sometimes when we talk about 2030, we thought it was so far away. We have just 9 years to 2030. Okay? And just about 2 years ago, the present government also subscribed to the Astana Declaration, which has to do with primary health care.
Yeah, I mean, we said at the beginning of the analysis that this...
at all these things.
So you're just repeating the point that we made at the beginning, that this is relevant.
Kampala, SDG 3, Astana Declaration, and all. What are we saying? What we are saying is that health is integral to development. And that for a nation to develop, just imagine a teacher who has to go to school and teach. If that teacher is locked down as a result of malaria, what that means is that the children are not going to be taught. The teacher stays at home as long as it is going to be. Imagine someone who maybe developed headache and could have just gone to a primary health care facility, okay, with cost not being the barrier. And maybe the headache was not an ordinary headache, but it was high blood pressure. So it was checked, and a very simple, inexpensive antihypertensive drug is given. The hypertension is taken care of. And what that means is that the person is not going to develop the complication of stroke and all to become a burden.
So we understand there's a need.
You don't understand.
I do. We understand there's a need.
You don't understand it fully.
Well, we do.
Because
of time, if you want to hit the nail on the head, the cost question is important.
I am hitting the nail right on the head, Evans. Evans, I'm hitting the nail right on the head. Just have patience. You see, do not go ahead if the value of the promise is not delivered to the people. Okay? Even if you say that it will cost 1 Ghana, they may say no or yes, because it is the money of the sovereign people of Ghana.
Okay.
That is why I'm saying that. So you need this free primary healthcare intervention, which has to do with primary care, which is more curative. There is also the preventive aspect of it, which has to do with screening. And screening is not always about maybe laboratory screening. Even blood pressure checks and those things are also part of screening. Checking temperature and all are also part of screening. So you need some of these things to be done. And what we are saying is that taking healthcare to the doorsteps of the people, where, like China did it some decades ago, barefoot system of delivering these things. And so you have a cadre core at every CHIPS compound. At least you should have about 2 community health nurses, 1 registered nurse, at least 1 midwife, and then at the full level, you are going to have a physician assistant. This will require further training of these physician assistants. Such that you are reaching out to the people in terms of outreach, health promotion, preventive health also being pushed. And when they are not well, they also are able to, you are able to pick it up early and get in touch with the system.
So that is your definition of when you say free.
When we say free primary health care,
that's what you mean.
That is what we
Okay,
do.
so let's go to the question.
We do not for one moment,
yeah,
okay, say that free primary health care takes away prevention, health promotion, and all.
So it includes all that?
It includes
okay,
all that.
so have you costed this?
Very
How much is it going to cost you to roll this out?
It has been costed.
Okay, how much?
Okay. Listen, it has been costed, okay? But you and I also know that even when you cost these things, you also have to also take into account, okay, certain factors. For instance, it is known that per outpatient visit, on the average, you will require between $8 to about $12 if I'm to convert it to that level for it. Presently, as we speak, the per capita outpatient visit, okay, for Ghana is 0.97, which means that the average Ghanaian visits the hospital less than once in a year. The average Ghanaian visits the CHIPS compound less than once in a year. But free primary health care is not exactly primary care. So what this also means is that if the person is not even visiting, a health promotion person, a preventive health person, will also be doing outreaches via radio and all to be able to reach out to these people. If you listen carefully to President Mahama during the outdooring of the Venerable President Nana Jim, he said that the free primary health care program is to begin, God willing, towards the end of 2021. And this is also based on the fact that we had costed it. We had also taken
So how much?
We had also taken into account, okay, the fact that COVID has come with some challenges that we will need to fix. And so if you say that you are going to start it right from January 7, even structural wise, you are going to have challenges. I've already told you.
Yeah, but I've heard that. But you haven't answered the question. You said you have costed it. So I want to know what the cost is.
Are you listening? If you were listening, you would have known that I've told you the cost ranges between $8 per visit to about $12. I've told you.
Okay, now, so I'm looking at it annually.
You see,
how much is that going to cost?
This is where you run into difficulties.
You?
Do you know why? Because when you begin like that, $8.
Yes, because we need to fund this. We need to know how to fund this.
Yes. Evans, you are jumping the gun. You seem to have a preconceived idea in your mind.
If we don't mind answering the question and making assumptions about what is in my mind.
I am answering. Yes. Listen, I'm saying that it costs, okay? Yeah. If you are taking it as a visit.
Yeah.
Okay.
I've heard that. I'm just asking annually how much is it going to cost you?
That depends on the number of people.
Yeah, but you must calculate. There are models.
Yes, we have done it.
That's what I'm asking. So if you've done it, just tell me.
We have done it.
Yeah, so tell me.
We have done it. And I'm saying that having done this, we also know that there is inefficiency, massive inefficiency. Will you be surprised if I tell you that for every $100 or 100 Ghana cedis that we spend in the health sector globally, the evidence suggests that about 65 to 70% of that is going waste.
Okay.
You understand? So, whilst...
Is that why you can't tell me exactly how much per annum?
It is part of it because we have costed it, but we also seek between that January to December where we will implement it to plug these loopholes, to be able to reduce it by not less than 60%. That is the $8 to about 12%. Reduce it by not less than 60%.
I have 2 minutes to wrap up on this, but I need to tell me the follow-up question, which I'm sure you've anticipated, which is where are you going to get the money?
Yeah, sure. And I
just have 2 minutes on this so that I could bring in your friend and colleague, your co-worker.
Yeah, if you don't mind, you can look at this.
The flow chart.
Yeah. So I have told you, one, in terms of costing, that as of now, you are looking between $8 to $12 per visit. However, inefficiencies alone is is over and above 60%.
Okay.
What that means is that if you are able to deal with these inefficiencies, and countries like Brazil and Costa Rica have done well, not too appreciable because they are even doing between 40 and 51%. We intend to even enhance it better.
Okay.
It means that the price will come down. To be telling you this is an indication that we have really thought through it and done the costing. I have just shared with you also a flowchart of the ecosystem when it comes to financing healthcare in Ghana. And so if you ask me where we are going to get this money from, the chunk of it is going to come from the consolidated fund, and in this case, specifically, the annual budget funding amount.
So this is oil.
Which is oil revenue. That is part of it. And then also tax and non-tax revenue that will be collected. This is not an indication that we are going to increase taxes, not at all. It is a matter of ensuring efficiency. And you see, sometimes I, as a politician and also someone who still has my social justice lens on, I get worried when, if government has to do something for the people, the question is about whether we are going to be able to do it.
Yeah,
my brother Okoboy sitting here, okay, if God willing, he leaves office on January 7. His colleagues who have served for 4 years, okay, are going to go home, each of them, with ex gratia, not less than 500,000 Ghana cedis. Okay, going to go home with not less than 500,000 Ghana cedis, each person. And it is not just restricted to them. It will involve members of parliament and all, not less than 500,000 Ghana cedis. If we are to spend less than $8, having put in the efficiencies on a Ghanaian who will be seeking primary health care, is it too much to be asking for on behalf of
Mr. Okoboy, so
it is not too much at all.
So he's laid out where the money is going to come from. He's talked about the breakdown. You have a similar proposal, by the way, which also burdens the NHIS. And as analysis have shown, you want to increase coverage. And the NHIS cover preventive and promotive. In fact, he has said in defining his primary health care that it includes preventive and promotive. Right?
Yeah.
And you want to expand that. So that's the parents who say they have this figured out quite well in terms of the numbers. In terms of yours, though, you already have a challenge with paying NHIS claims.
Yeah.
So now you're extending. This is going to burden you. It's going to make an already bad problem that you've had faced even worse.
Yeah. Thank you very much, Evans. I'm so happy you started with the question of the funding or the cost. Wanted to know how they are going to, especially when my senior colleague belongs to a tradition that promised us that they were going to give us one-time premium for health insurance. You see, if they had even come to tell us the difficulties...
So this is a track record question that you're posing.
I mean, credibility. When someone has been at a particular place before and the same person tells you, I want to do this, you want to check what the fellow did the last time they were there. It's very important. If you have two people who have never occupied an office, you can only put your trust on their promises and hope that they deliver. But for the one who has been there, you must be interested in their record when it comes to fulfilling the promise. Even if they are not able to fulfill, the efforts they make is very important. You see, if they had told us the difficulties they encountered in trying to even implement that particular promise, I would have been very grateful or appreciative of their effort. But really, they didn't even want to tolerate discussion on a matter as if they had never mentioned it to us. So that tells you the record. And you see, if you can tell Ghanaians that you want to do one-time premium, which in any case is going to help take care of primary health care. Because if you, in fact, the last time I was having a discussion with one of the technical officers at Ghana Air Service, he used an equation which was very interesting. Primary health care, the free primary health care is equal to a functional CHIPS health center or district facilities plus a very vibrant health insurance scheme. The point is that effectively, as we have in Ghana now, if anybody walks to a health center to be taken care of for malaria, once the fellow is having insurance, they don't pay anything. But it is when your health insurance is troubled or not working properly that the elements of co-payment or some cash is usually demanded.
Are you suggesting that free primary health care already exists?
No, if you derive, it's not wrong. So I'm happy.
So I'm just clarity.
I'm coming.
So
it's just to tell you that the value of that promise is even small. Because what we have...
So you're not categorically saying that it's already free. We're saying that it's... More
or less. What we have currently, because the fellow will pay for the processing of the card, I'm careful to use the word free. Because if you are exempt from paying contributions, let's say I pay a SNIT contributor. When I got my card the last time, I only paid for the processing. I think it was 8 Ghana cedis or so. There are folks who can be kept away because of that 8 Ghana cedi. So I am careful to use the term free. But the point I am making is that once a citizen has a health insurance card or is part of the scheme, they access 95% of conditions in this country without paying anything. It's a fact.
40% of citizens.
You get what my point? Now, so really, if you want to improve access to health care and let people get the care they need, you must make sure that your health insurance scheme is very vibrant and efficient.
Yeah, but
that is
but currently, going back to the question I asked you earlier, we know that the national health insurance has struggled in the last 3-4 years.
Answer, it's not
no, but you are promising to extend and increase the burden of the NHIS.
I'm coming. I think the first point that the health insurance we came to meet had challenges with access, even clients going to renew their cards. Yeah. You go there at 5 a.m., you have a huge you have a long queue. People wanted to just renew their cards. What did we use to break that queue and eradicate it? What did we use? Technology. *929#. In the comfort of your bedroom, you renew your card. Folks are renewing their cards in their rooms. They don't go to the district office anymore. And that is what competence can do. That's the first one. So we've been able to take away that significant challenge, which you meet a lot of people in the hospital. They come to my consulting. Why have you not renewed your card? When you go there, there's a long queue. You have to go there at 4 a.m. just to renew your card. Now you do it in your bedroom. 2, there was a serious problem also with processing of claims. A lot of the claims were being done manually. The validation, the claims that the health providers submit. Because it was manual, it was taking a lot of time. And there was the element also for, what's the word, for abuse, corruption. You understand? Where you can have a man, you can have someone go to the hospital, a guy, and sometimes comes out at a fellow at cesarean section, just because what you pay for cesarean section is higher than just some OPD drugs. Secondly, you have people, and these have come out in the audit. You have an individual going to a hospital, he's not admitted, but the books will say that he was admitted for 3-4 days. They will write some drugs just for him to get. Electronic processing was proven or had been proven to take care of some of these things. So we've increased significantly. I was trying to get the exact percentage. The processing, majority of the processing now is done electronically and not manually.
Without the numbers, it's hard to believe what you're saying.
But that's why. But Evans,
without the specifics,
Evans.
Fortunately, you are the deputy health minister. So when you
Evans,
come,
I am not,
and don't come with facts.
Evans, no, I'm not a walking encyclopedia.
No, I have you could have pulled the document.
But I have stated the challenges. I just mentioned *929. I didn't see you tell me that I didn't come with facts.
Because you mentioned some facts.
Yeah.
I can do start. No. It's all about facts.
Absolutely. But my point is that if you want to improve on national health insurance, their performance, you must work to fully do electronic processing.
I get it, but you still haven't addressed my question.
Exactly. When it comes in, you ask for the direct percentage. But you have deviation. Doc, you did a lot of foundation before you came.
Okay.
Now,
so you also laid foundation.
Of course. Now, payment of claims. They owed an average of 12 months, 12 to 40 months before we came to office. You can check with anyone who works with health insurance.
Yeah, I mean, Dr. Abeka in analyzing, make the point.
3 days ago, the daily graphic I read, you had service providers, even private service providers, coming to commend the health insurance for paying. The last time I checked, they had paid up to April.
But you haven't eliminated that problem. You're still 4 months behind time.
Okay, let me explain. But Doc understands. The process itself, allows you statutorily to have about 2 to 3 months of gaps.
Doc, what is the discussion?
Doc,
are we discussing national health insurance?
Doc, you are not the host. Please, Doc, you are not the host.
Just a second.
Let me land. Doc, you are not the host.
We will speak to national health insurance.
I think just a second.
Oh, yeah.
But their promise on NHIS.
Yes.
To cover under NHIS.
But we also have a promise under NHIS.
Just a second.
Evans, it's important to do some education here. The way
he knows. It's more important to answer the question.
In answering your question, education comes in.
Okay.
And you will also be a beneficiary. Of course, Evans, the way the National Health Insurance operates, if I operate Okoboy Hospital, I submit claims. Even with the most efficient of processes, you will not get results, the validation in the month.
I get the point.
Absolutely.
So let's come back to what you're doing.
Yes, so my point is that you said we owe about 4 months. And I'm telling you, even statutorily, in process-wise, you would always have some 2-3 months which you must take out of the period. So that if you are saying 4 months, really what we owe is 1 month. Because you need some 3 months, which is the period allowed for the claims to be worked on, validated and paid. So that they owed an average 12 to 14 months.
My brother,
we have...
That is not true. That is not
Look,
true.
I'll come to that. Please make a note for me.
It's a statement of fact. This government, if you ask any practitioner, any private hospital operator, this government has reduced significantly the arrears period.
They were Doc.
I said I just read Daily Graphic 3 days ago.
But Doc, it's a fact that in the last 3 years, the providers have threatened. They have threatened several.
Yes, I agree with you.
You agree?
I agree with you.
Yeah.
But my point is...
Let me go to my question on the back of because that's my question.
Yes.
On the back of that, you are promising to burden the NHIS even more.
Exactly. All right. Okay.
In the midst of all the challenges that you already have. My question is, where are you going to get that extra money to fix the challenge that you already have on your hands?
The challenges...
With the burdening, they further burdening of
the challenges are not insurmountable.
No, but you have to address the question. Where are you... He has told me he's going to get it from oil, right?
And consolidated fund.
Where are you going to get the extra money?
But if anybody tells you that he's going to get funds from consolidated fund, is it not, what's the word?
No, it's just oil.
It's extraneous.
Yeah, I mean, I get a point.
Of course, if you're a government,
he's narrowed it down. He's not. At least I pushed him and he did some cost analysis. He may disagree with his analysis, but he's done a cost.
My senior tells me you get funds from the consolidated.
I get the point you're making.
You can't disagree with the analysis because the $8 to $12.
Doug,
he's not. Sorry,
it's a fact.
Doug, at least he did some cost analysis. You may disagree.
So
but where's yours? How are you going to fund this going forward?
You can only pay. You can only what's the word? You can afford something when you've created the wealth or the resources for it.
True.
Why did they stop the allowances for nurses? Please, it's important.
How is that related?
No. Listen, you don't have the patience. Please, why did they not employ those nurses who sat at home with 3-4? It's because
Evans,
because when you
I've sent you a link.
Because when you grow, when you grow an economy, you are able to get. When you grow
on employment of nurses,
when you grow an economy, you are able to create more opportunities and afford both projects and recurrent expenditure. Recurrent, like employing workers in the public space, and capital infrastructure, as in investing in projects. So the bottom line is that I think Dr. Abaka said it, that because of COVID, if you are expecting some percentage flows into the NHIS fund, once there is a dip, it will affect the flows. In the same way, if there is significant economic growth, in terms of when you create wealth, you'll be able to increase the amounts of money that go into the fund. And we are going to build an economy that is very robust and resilient, that can sustain and support the national interest.
You haven't narrowed down where the fund is going to come from.
But the 2.5% from SNIT contributions.
It hasn't been enough.
No, but he told you it will even dip with the COVID.
But that is what makes my question even more relevant.
Absolutely. You see, as a country, we are safer with a national health insurance that increases its inflows so that it can support other programs.
How are you going to increase the national health insurance inflows?
No, well, obviously, I'm not going to sit here and assume, if you read the Act 852, the Health Insurance Act, it mentions sources of the flows into the fund, the levies, the premiums, the fees and all that. I wouldn't arrogate to myself the power to mention the other sources. But my point is that obviously we have to increase the inflows into the fund so that we can cover other services. And it's because of that anticipation that with time, there will be the need to expand the coverage. That's why you had Section 34, which talks about a review of services, and 33, which talks about the inclusion of medicines. As we speak, Herceptin.
I'll come to you so that you can.
As we speak, Herceptin, which is how do you call it, an anti-cancer drug, a very expensive one, has been roped in because research showed that a lot of patients are in need of that drug. It will come with cost implications, but we've included it because we are also working to make sure that the inflows are improved.
Okay, so I mean, listen, you can make up your minds about both sides you've heard, but Doc, let me come to you.
But Evans, just a little.
I'll come. Please, I'm asking a substantive question. Okay, you have 2 minutes to answer that. I'll come back to you later on this, and then you can add that what you want to add.
Okay, no
he at the beginning raises the track record question that you promised one-time premium that you have abandoned. Now you're promising free primary health care. He says, why should we believe you?
Look, if Ghanaians can believe the MPP, that promised 350 senior high schools in 18 months, okay? MPP promised to build 350 senior high schools in 18 months, okay? If Ghanaians should believe them, and they still have the audacity to be making promises to Ghanaians, if Ghanaians should believe the MPP, that promised that in 18 months, and candidate Akufo-Addo made this promise himself, he would transform this country, okay, then they should rather be understanding why a major recurrent expenditure like the single spine, which was completely unanticipated in the 2008 manifesto, but President Kufuor visited it in one of his last-minute endeavors, which even led to the freeing of Mr. Chikata and all. He just signed that and said it should be implemented. Some of those heavy expenditures
made it impossible to implement.
Caused the challenge, you understand? But you see, the issue that he's seeking to raise, to profit from, I'm raising two things. President Akufo-Addo promised to transform this nation in 18 months. He's gone past 18 months. Okay. Shouldn't he be booted out? Secondly, they promised 350 senior high schools. Where are we as we speak now?
You're going to address some things quickly because I need to move to him.
I'm saying that, Evans, if you are not careful, you will not do any good service to the very good people of
No, because I don't have to. I have 15 minutes to wrap up, and so we have to get into this.
You asked a question about how they are going to cover Ghanaians in terms of the provision of primary health care. And so far, he has not answered it. He's saying that NHIS, and I'm suggesting to you that the NHIS route is a no-go area. It will not work.
Why?
Why will it not work? From 2003 to date, it is still under 40% in terms of coverage. Okay? From 2003 to date, 17 years. We have from now till 2010 till 2030, 9 years from now, to achieve universal health coverage. And you tell me that a scheme that is growing on the average about 0.8% at this stage, because if you look at where we are now, they are going to be able to cover every Ghanaian. That is not going to work. So what do I mean? I'm saying that their route doesn't work, and it will collapse the national health insurance. That is why we are saying that the free primary health care approach, which separates the national health insurance.
So you're not going to rely on NHIS for your free?
The national health insurance, we have spoken about it that's why I was asking. Is this a discussion on national health insurance?
No, but that is a question to him, because they are relying on the NHIS.
Fantastic. And I'm saying that will not be achievable. Then they may be going a route which may take us maybe several decades. Okay. Because from 2003 to date, we are still under 40%, about 39-point-something%. Okay. You understand?
Let's move to another area very quickly.
Just with your permission, just 2 points. He spoke about health insurance. Yeah. Let me advise him on how they can even currently improve on the financial health of the health insurance scheme. And we have captured this on page 66.
When you couldn't achieve the one-time premium.
7.1.4. That is the paragraph. We are saying that we will exclude the NHIL from all VAT exemptions granted. One. We also said we will enforce the provisions of the National Health Insurance Act 2012, blah, 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 section 54, which requires the Minister for Finance to pay directly into the National Health Insurance
I'm
Fund.
Sorry, in your time, you failed to respect this. You failed to respect
And we are saying,
your track record on this is not good.
That is why I'm telling, and we are making the promise that we will do it.
How? But you didn't do it in 4 years. How can you? Why?
In 8 years.
So.
Just a second.
So Evans.
John Mahama, 4 years. 4 years. This was consistently not done.
So Evans.
I'm very sure Setekwa is listening.
Evans,
consistently telling us and explaining why he couldn't respect the law.
Evans, are you saying that because you couldn't do something yesterday?
That's track record.
It means that tomorrow you'll not be able to.
John Mahama at the launch of the manifesto said this year is going to be about track record.
I've told you President Akufo-Addo promised that in 18 months he was going to transform this country.
But that's Akufo-Addo. We're talking about your promise
Who is Akufo-Addo?
to respect the law that you failed to respect in 4 years.
Akufo-Addo is the president of Ghana, and you don't want to hold him by the same standards.
I'll hold him to it. But this is you, the NDC.
Evans, I'm saying that President Akufo-Addo said he was going to transform Ghana.
I'll hold him to it. But let me hold you to yours.
Yes, so we are saying that going forward.
But do you admit that in 4 years you failed to respect that law?
We are saying that going forward, this is what we are going to do.
No, but you admit that you failed to do it in 4 years. Excuse me. In 4 years you failed to respect the law.
Listen, I'm saying that.
So what has changed? What has changed between 4 years and the future?
This is
the 20 election.
This is because there is the need to strengthen the National Health Insurance Scheme. What this government has done to the National Health Insurance and other statutory funds
to win power
is terrible. Okay. DACF. Capped.
Now you are lost.
Realigned. Capped. Realigned. What I'm suggesting to you is that you cannot say that because in the past A followed B. Therefore, in the future,
I want to move to an area that you like. I mean, I
like all the areas.
Infrastructure.
You see, because of COVID.
No, I'm holding you.
No.
Because of time. Let's do this very quickly. Infrastructure. Let's go to health infrastructure very, very quickly. We'll take the break after this. Now, Dr. Koboy, your manifesto is very heavy on health infrastructure. In fact, if you look at your manifesto, it's the biggest line item in there.
I was even too charitable. I said the NHIS was growing at 0.8% annually.
It's growing at what?
No, from 2017 to 2019, the growth has been 0.8%.
Okay, good. No problem.
So it's a no-go route.
If it disagrees, he'll let us know.
He cannot disagree. But
Dr. Koboy, this is a question on infrastructure. Disagree. You are promising to undertake Agenda 111, right? Build 101 hospitals, health facilities across the country, including 88 main ones. That's the first one the president promised. When he first made a promise, Agenda 88, this was in April, in the heat of the COVID, and in his 8th address. He said, we will this year begin constructing 88 hospitals in the districts without hospitals. This was in April. It will begin it this year. You have 2 months for the months to the 3 months. I mean, the October, November, December for the year to end. How many of the 88 hospitals have you actually started?
Yeah, well, I'm coming there. By the way, remember, we promised to restore allowances that were withdrawn. We did it. So credibility is very high in terms of promise.
So back to the question. How many of the 88 have you started?
Yeah, I think it's important to mention even those ones that we have secured funding and have started now before I even come to the 111.
It's all part of it.
Of course, because it's important. Most of the facilities, La General, Tema General, Kolibu, the nephrology unit, Confanochi, all are outside Agenda 111. So we have a regime that is doing one of the biggest investments ever in healthcare. The good thing is that, you see, we came to meet some facilities that they had started, 10 polyclinics in the central region. We've completed all. The University of Ghana...
So you have 3 minutes. You also have 3 minutes. So
the University of Ghana Medical Center that they mentioned in their manifesto, phase 2. In fact, in May 2019, in Parliament, we've approved of the, the facility. Cabinet parliamentary approval secured. Contractor is on site. Phase 2 going on. And yet they say they will continue with phase 2. So I think some of their promises came rather too late. Now, if you also look at the NMS projects, the NMS refers to those projects at Tepa, the projects at Fomena, Kumewu, the one at Garu Timpani and all that. These were projects, I brought some correspondence between the contractor and Alex Sigbefia. They had serious challenges with meeting the contract period and asked that they extend their LC period. It was expired before the end of 2016. There were issues back and forth. In fact, they were supposed to build a number of hospitals. The money that was allocated to the projects was misapplied for other things. As a result, they couldn't finish with those funds. So we had to go through some engagements. The NMS, so Dodowa, Famena, Kumewu, Abetifi, Garu, Timpani. These were started under the NDC regime. When we came, we also continued. And Dodowa, as you speak, is completed. The contractor is on site for Famena, Kumewu, and all that.
Dodowa was completed and commissioned by John.
Yes, it's Dodowa. No, I said it's completed.
I was there.
I'm not saying we
commissioned. I was there too. I'm fact checking it. So what's the point of mentioning it?
My point is that they completed some. They had serious challenges.
No, with Dodowa.
They completed Dodowa.
I was there. Yeah. John Benjamin, the then ambassador.
It's clarified.
But he was trying to slip it through.
Why would I fact check? I don't need to slip through. My point is that
he was trying to slip
they had
so
a facility.
Take Dodowa out.
No, you don't get it. Listen.
Okay.
I said
let me explain.
I'm trying to address that propaganda that we abandoned projects they are starting.
But Dodowa was already fully done.
Listen, you should be patient. The NMS company.
I have videos here for you.
Look, it's an amount of $175 million.
Yes.
To build the Dodowa Hospital, Fomena, Kumewu, Abetifi, Garu Timpani.
I think you secured the funding for this.
What?
You secured it.
I said this funding, this amount was supposed to take care of all these projects.
Yes, okay.
But along the line, most of them stalled.
But Dodowa
was completed.
Okay, yes.
Exactly.
That's exactly. Kind of, okay.
You see, they've been making the point that we have deliberately abandoned those projects.
Okay, wait. You just have the 2 minutes now to wrap up on this.
So my point is that projects that they started, we have come to continue with our projects. Okay. That's the point.
So the question now, how many of the 88 have you started? Because you say you start this year.
The last time I had a meeting with the coordinator, the team, all the feasibility works, the sites, the inspection and all that, topographical, he knows better. When it comes to hospitals, all the checks you have to do, all those things are.
So are you saying that you've started all the 88 already?
I mean, all the sites have been visited. We are looking at places where, it's one of the biggest programs that would ever be done.
That's a bit about tapping yourself in the back. But the question.
No, if you have 111 projects, there are some that will kickstart before
about 88.
Others.
The president said 88 will start this year. My question is, how many have you started?
I know that works is ongoing in terms of the feasibility, the documentation.
So you haven't started any?
No, but these constitute part of the project. Can you start a project without securing the documentation?
Well, when the president says start us in the brick and mortar starting.
I mean, you see, my point is that all these things, without them, you cannot complete or even have a structure. So, and that's very important.
Okay, finally,
let me
he needs to take a stand now.
Finally, let me say that as you speak, like I said, the Tema General Hospital, which is a facility I've worked before, for 8 years they were in power. It remained the same. We have secured funding to turn it into an ultra-modern facility. La General Hospital was a death trap. For 8 years, it was the same. We have gotten the facility secured. A contractor is, a contractor is supposed to move to site. The maternal and child block at the Community Teaching Hospital started in the 70s, had been there for over 40 years. It has taken this government to secure the funding and the contractor is on site. Kolebu Teaching Hospital, the maternity block has been a death trap with cracks. It has taken this government to secure the funding. A contractor is on site. Good. Nephrology and urology center. So the point is that when it comes to infrastructure, we have continued with what they started. We have commenced new ones on our own, and we have agenda 111.
You have 5 minutes.
Look, my brother.
On your infrastructure intervention.
Yes, on infrastructure. We promise that, look, not only are we going to deploy infrastructure, but we are also going to build at cost-effective amounts. Okay? We are not going to build a district hospital in Shama at $39 million, which is 100 bed, when it can be done, let's say, at $25 million for 120 beds.
So you're going to do for less?
Yes, you do it for less.
That's a fraction.
Okay. My brother, $39 million and $25 million.
It's huge. That's the point I'm making.
Yes.
The difference is huge.
Yes, it's huge.
So what is accounting for your low figure?
Even President Mahama did it. He constructed 120 beds at $25 million. And they are doing one in Shama at $39 million. You understand? And that is even 100 beds.
We have to check. Because the
That
last
is,
time,
Oko, you know, that is even 100 beds.
we'll check.
My brother, we are saying that this government, one of their sins against humanity, the good people of Ghana, has to do with the hospitals that they abandoned. I'm still looking for. Listen, I'm still looking for that gentleman.
Tepa was commissioned today.
I'm still looking for that gentleman who held a placard and demonstrated
in front of the president
and triggered the conscience.
UGMC
and triggered the conscience of this government before they activated the UGMC.
But Doc, are you aware Tepa,
Only God,
has been
please,
commissioned
please,
today?
please, please, don't do it, Donald Trump.
It's time.
Don't do it, Donald Trump. Here. Okay, I'm still looking for that gentleman. Okay, and if anybody has his number, they should text it to me. Can you imagine if that solo demonstration had not been done? Where would the education minister, when he had a COVID, have been? Where would the health minister, when he had COVID, have been? Where would many Ghanaians who unfortunately had COVID have been? Yet, it had to take a single Ghanaian to demonstrate for you to activate the University of Ghana Medical Center.
But who says he took that demonstration
and then even when you wanted to bring on stream the Bank of Ghana Hospital, this government had the effrontery, permit my saying, to tell Ghanaians that that was going to be used for VVIPs for COVID.
Evans, you have to correct.
This is their mindset when it comes to health infrastructure. Okay? We are saying that, look, we are going to provide district hospitals. And there too, there's a difference. Just like when it comes to free primary health care, there's a difference between what we are promising and theirs. They seek to use national health insurance. Are proving that is not possible.
You provide budget.
When it comes to district hospitals, we say provide. Let me cite an example.
Briefly, because the time is almost.
You go to the Eastern, and there's a place like New Dublin, North. It has a hospital that is doing very well, St. Joseph Hospital, one of the best orthopedic centers in this country. Are you better off working with the Catholics and boosting the capacity of St. Joseph Hospital to convert it into the district hospital that will serve the enclave? Or just because COVID had come, the MPP government had been exposed, so the president just came and made the promise, I will construct 88 district hospitals. So that a place like Akwatia in the eastern region, there's the St. Dominic's Hospital, which is already doing well and serving as a very, very good district hospital. Will you look at improving that? Or you will look at going to situate another hospital, brick and mortar, even at a higher cost like they are trying to do in Shama there. So our promise about the provision is that where there is a facility, that facility will be upgraded. And where there is no such facility,
that's where you actually build on.
they will be given.
Doc,
and this is also one of, I think, the limitations of Dr. Abake's analysis, where he lumped the two together. They are talking about construction. We are talking about providing. The provision is that in certain cases, it will be constructed. In certain cases, you will see upgrades.
Doc,
I'm
grateful.
Cost.
I'm grateful. I can't shake you, but I can do this.
But upgrades will happen.
Thank you very much. Now, thank you, gentlemen, for joining me. There's a whole lot to still go through. We'll continue this conversation. I need to have a second part 2 of the health because there's so many more to do. Join us again next week. Possibly we might return to this conversation again and see whether we can delve into this even deeper. My name is Evans Benson. Thank you, gentlemen, for your time. Enjoy the rest of your evening.